Okay, so you've had some shoulder pain lately and you think, maybe I need an MRI on this. It's logical to try to want to see what's going on in the shoulder, right? Or maybe your doctor already ordered an MRI and it comes back and it shows, oh, you've got a partial tear of your rotator cuff, or you've got a labral tear, or a type 2 acromion. And these things sound really scary. So then you get coerced into some newfangled, expensive experimental injection or a surgery. And what if I was to tell you most MRIs of the shoulder are completely unnecessary anyways, and all those things that I just mentioned are pretty much just normal findings anyways. What you have to understand is that these structural pathologies, quote unquote, that we see on MRIs, they're not proportional to people's pain. That's one thing that people don't really understand about the world of MRIs. So if we look at this study here where they looked at 50 elite rock climbers, what they found was that in those rock climbers who had no shoulder pain at all, there was tendinosis in the rotator cuff in 80% of the shoulders, and then subacromial bursitis in 79% of the shoulders, and long head of the biceps tendonitis in 73% of the shoulders. Labral pathology was present in 69% of the shoulders. And then discrete labral tears, like frank tears of the labrum, was present in 56% of the population of these elite rock climbers that they looked at. And then articular cartilage changes weren't uncommon either. So yet none of these people had pain at all. And so then you think, well, maybe that's just because these people were older, right? I mean, the average age of this study was like 20 to 60. So let's look at another study on younger people. So this study was done on Little League baseball players, and they looked at MRIs. And again, these Little League baseball players had no shoulder pain at all, but yet they found 52% of the players had abnormalities in the shoulders, ranging from rotator cuff tears to labral tears and bursitis. Now, we all feel pain differently, and our perceptions of pain vary person to person, right? Like, if we're catastrophizing our pain, or if we're not sleeping well, or if we're really stressed out, all these things lower our threshold to feel pain, right? You hear people say all the time, oh, I have a high pain threshold. And so maybe the people in all these studies, and there's more studies than the ones that I just mentioned, but maybe the people in these studies just have a really high pain threshold, and that's why they don't feel pain despite the fact that they have all these structural, quote unquote pathologies on the MRI. So one way to account for that potential bias in our pain threshold is to look at MRIs of people who have pain in one shoulder, right? And then take an MRI of their non-painful shoulder at the same time and see what differences are there. And then that way you can account for that person's level of global inflammation in their body, or their perception of pain, or whatever. Well, that's what this paper just did. And what they found was that these supposed quote unquote pathologies were virtually identical on the painful side versus the non-painful side. The only significant difference between the painful and non-painful sides was with respect to the full thickness tears of the rotator cuff. In other words, when the tendon was completely torn through. Otherwise, all the other pathologies were present at the same rates on the painful side versus the non-painful side. So maybe these tears and deformations aren't really what's generating the pain in most cases. So if you're being convinced that you need this experimental, expensive injection, or even riskier surgery, you should ask that healthcare provider if they're positive that that pathology that you see on the MRI is really what's causing their pain. And would we not see the exact same thing on the other shoulder? And if we would see the same thing on the other shoulder, why aren't we doing surgery on that side too? Because it's not painful. But all these other studies say that those types of things aren't painful generators anyway. So you really have to wonder, is the treatment being based on the MRI and the image, or is it being based on what is actually generating the pain? So what I would encourage you to do is just really make sure that you dial in your rehab, you stay with it for a long time, you stick with dialing in your diet as well, because your diet has a big role in your creating this environment for healing. Right? So if we look at this was best said in this study in 2018 when they looked at all the available research, and they concluded physiotherapy was as effective as surgery in both the midterm and long term for pain, function, range of motion, tendon force, and pain, treatment success, and quality of life, respectively. And they concluded, we recommend that healthcare professionals who treat tendinopathy encourage patients to comply with loading exercises, in other words, rehabilitation, treatment for at least 12 months before the option of surgery is seriously entertained. And that's simply because you're going to manage the pain through conservative management just as well, if not better, than surgery, minus all the risks. So just food for thought there. If you ever want to contact me about any of this, please let me know. Thanks. Bye.